Bismillah ar-Rahman ar-Rahim. Our lecture today about the ankle and ankle fracture and ligament injury around the ankle. Start within the anatomy of the ankle joint. As you know, the ankle joint formed by the lower end of the tibia, lower end of the fibula, articulated with talus. This is the mortise joint, and also there are medial and the lateral ligament. The lateral ligament includes three bands: the anterior tibiofibular ligament, the posterior tibiofibular ligament, and calcaneofibular ligament. While medially there is a deltoid ligament, which is superficial and deep band of the deltoid. Also, there is another joint between the lower end of the tibia and fibula. This is called the syndesmosis joint, which is reinforced by anterior and posterior intertibiofibular ligament. Regarding the biomechanics of the ankle joint is a triplane. The load-bearing force in stance phase about 4 times the body weight, and normally range of movement about 20 degree in extension and 14 degree in flexion. نحتاج على الأقل 10 degree of the dorsiflexion, extension, for normal gait. بنفس الوقت when 1 millim of the lateral shifting of the talus, this will decrease the tibio-talar surface contacts about 14%. لذلك الأنكل joint يحتاج accurate reduction and stable reduction. Otherwise, there is difficult in the walking and the running. Regarding the radiological evaluation, how you can evaluate the ankle joint? Start within the plain film. And the plain film, we have many modality. Number 1 is the AP view. Number 2 is the mortise view. The mortise view is the AP view, ولكنه الfoot or ankle is internally rotated about 15 degree. Lateral view of the ankle. Need the entire tibia should be observed and the fibula by the X-ray until to the knee joint. لأن sometimes missed injury اللي هو المازونيف fracture. Foot film, it is ordered if there is associated with the fracture, and the common fracture in the foot is a 5th metatarsal base fracture and calcaneal fracture. This slide analyzes the quantitative analysis of the ankle joint, and thus will be decided whether it is a stable or unstable ankle. Number 1 measurement is the tibiofibular overlap. This is the tibiofibular overlap, and this should be more than 10 millim, أكثر من 1 سنتيم. The next parameter is the tibiofibular clear space. This is medially to the fibula and should be normally less than 5 cm. The third parameter is the parallel of the inferior surface of the tibia with the superior surface of the talus. And the last one, this is space is similar to the space between the medial malleolus and the talus and equal to the 4 millim. This is the mortise view, اللي هو 10 to 15 degree internal rotation of the ankle, and the X-ray is the AP to the ankle joint. This is the mortise view. The abnormality in this mortise view showing that the medial joint space is widening, and also there is not parallel of the inferior surface of the tibia with superior surface of the talus, and also the overlap between the tibia and fibula is less than 10 ملم. إذن هي unstable ankle joint. Other imaging modality start within the citrus view, sometimes needed, especially when there is ligament injury, either by gravity نخلي الانكل على pillow والجرافيتي هي راح تسوي citrus view, or manually we manually will be put the foot and the ankle under citrus. Also sometimes needed CT scan, and CT scan needed especially when the joint is involved, when there is a posterior malleolus fracture, or for pre-operative planning, and also for evaluation of the hind foot and midfoot if it is injured. And last imaging is the MRI, and it is important for the ligament and the tendon injury, or the talus gum lesion and syndesmosis injury. Start with the ligamentous and tendon injury around the ankle joint. The ankle sprain are the most common of the all sport injury, and it account about 25% of the cases. In more than 75% of the cases injury the lateral ligament complex, and it is either sprain ankle, which is mean a painful wrench of the soft tissue, or strain ligament, which is more severe force, and the ligament may be ruptured either partially or complete. When partial tear, most of the ligament remain intact, and hence it is when held it is able to support the weight of the body, while when the complete tear of the ligament may still have ability to heal but never return to its original form, and the joint will be probably unstable. Physical examination of the ankle sprain should be palpated over the medial and the lateral malleolus, palpated over the deltoid ligament, palpated over the anterior tibiofibular ligament, calcaneofibular ligament, and posterior tibiofibular ligament. Neurovascular examination is very important, and also squeezing test to identify whether there is a syndesmotic injury or not. And this test is done by squeeze of the just above the ankle by hand. Ankle sprain, most common mechanism of the ankle is inversion stress with a plantarflexion, and thus result in the lateral collateral ligament injury. A history of a twisting injury followed by pain and swelling. If the pain is able to walk and bruising is of only mild and slowing to appear, it is probably a sprain. If the bruising is marked and the patient is unable to put any weight on the foot, this suggests a more severe injury. Also, tenderness is maximal, just distal and slightly anterior to the lateral malleolus. The slight attempt at passive inversion of the ankle joint is extremely painful. Common misdiagnosis within the lateral ankle sprain is the peroneal tendon injury and Achilles tendon injury, and sometimes fracture, whether fifth metatarsal fracture or Lisfranc injury, which is mean injury to the tarso-metatarsal area. About 15% of the ankle sprain associate with ankle fracture. Thus, X-ray examination is indicated in the following condition. يعني احنا مو كل ما نيجي ankle sprain يحتاج X-ray، ولكن certain indication اللي هي 4 indication for order of the X-ray examination. Number 1, when there is a pain around the malleolus. Number 2, when there is inability to take weight on the ankle immediately after the injury. Number 3, inability to take full step in the emergency department. And lastly, when there is any bony tenderness at the posterior edge or the tip of the medial or the lateral malleolus or the base of the fifth metatarsal bone. The X-ray is the anterior, posterior, lateral, and mortise view of the ankle, which shows the soft tissue swelling or avulsion fracture of the tip of the lateral malleolus. Sometimes need citrus view, citrus X-ray, اللي هي also called the Taylor tilt test during force inversion 15 degree of the tilt. Any more than 5 degree differences than the normal, it is a diagnosis of the ankle instability, which is mean complete tear of the lateral collateral ligament. For a patient who have persistent pain with swelling and inability and impaired function over the 6 week of the duration, بهالحالة راح نحتاج more intensive evaluation by MRI and CT to assess the extent of the soft tissue injury and subtle any bony damage or changes. The medial ankle sprain, it is account about 5% of the sprain. It is mechanism usually force eversion and usually injury to the deltoid ligament and may be associated with syndesmotic injury. And the rupture of the deltoid ligament is usually associated with either a fracture of the distal end of the fibula or tearing of the distal tibiofibular ligament or both. The effect is to destabilization of the talus and allowing to move it into eversion and external rotation. The diagnosis is made by X-ray. There is a widening in the medial joint space in the mortise view. Sometimes the talus also will be tilt and diastasis of the tibiofibular joint may be obvious. When there is a deltoid ligament or medial malleolus injury but not apparent lateral disruption at the ankle joint, it is important for looking for the fracture or dislocation of the proximal fibula, which is called Maisonneuve fracture. And this is the Maisonneuve fracture. Maisonneuve fracture is the fracture around the ankle joint ولكنه associated with injury to the upper part of the fibula. Regarding the management of the ligament injury, we start within the رايس. سابقا كانت وهسه بالجديد برايسر اللي هي مختصر برايس rest, ice, compression and elevation. While the Pricer, it is protection, rest, ice, compression, elevation and rehabilitation. Usually within the ankle brace initially and protected weight bearing for grade 1 and grade 2 with the range of exercise. The bracing يبقى for 4 to 6 weeks depend on the activity, and sometimes the sprain may be required for 6 months. While for grade 3 sprain may be require a walking boot or cast for the 4 to 6 week, and sometimes it is required surgical management when there is a sign of instability of the ankle joint. The next injury is the Achilles tendon injury. Regarding the anatomy of the Achilles tendon, the Achilles tendon is about 10 to 12 cm long and about half to 1 cm diameter, with a vascular zone about 2 to 6 cm proximal to its insertion. And the fiber of the Achilles tendon is rotated 19 degrees at the insertion to the calcaneum. Usually the patient presented with acute pain in the back of the ankle and contraction, not antecedented history of the calf or the heel pain. Usually occur within the young age group, about 35 years old, and also we see in the steroid patient or patient on the fluoroquinolone, and the chronic overuse may be predisposed also to the fracture. Usually the fracture occur about 3 to 4 cm above the Achilles insertion اللي هي area of the avascular zone. Regarding the examination, usually there is a tenderness over the Achilles tendon, sometimes palpated gap, and we have Thompson test اللي هو ننيم المريض على الكاوتش ونطلع الفوت out of the couch، ثم نسوي squeezing للكالف muscle، راح نشوف there is elevation of the foot. The similar is the needle test، انه نحط نيدل بحدود 10 سنتيم from the insertion of the Achilles tendon ونسوي squeezing للكالف muscle وراح نشوف ال movement of the needle in the tendon. Regarding the management, usually in the young active patient need surgical repair, while non-operatively it is considered for the old patient with increased risk of the soft tissue complication like patient with insulin dependence, diabetes, smoker, and vascular disease. Generally, we need short leg cast strategy or long leg cast strategy for the when you consider conservative treatment. Many of the authors prefer to the long leg strategy casting، يعني يجبس المريض in ankle in plantar والتجبيس يصير فوق الركبة لأنه ال origin of the gastrocnemius is above the knee. This is continue for the 6 weeks followed by short leg cast اللي هو ينزل الجبسونة جوا الني for another 4 to the 10 weeks. Regarding the ankle fracture, and start within the malleolar fracture or ما يسمى boot fracture. Boot fracture and fracture around and fracture dislocation of the ankle are common, and the mechanism are usually most of them are low energy trauma of one or the both malleoli fracture, usually caused by twisting mechanism. Less common are the more severe fracture involving the tibial plafond, the pilon fracture, which are high energy injury often caused by falling from a height. Regarding the pathological anatomy or the classification, the simpler classification of the malleolar fracture is that obtained by Dennis and Weber, which is based on the fracture of the fibula. قسموها إلى A, B and C تعتمد على الفراكشر fibula. إذا الفراكشر fibula below the syndesmosis is a type A، إذا الفراكشر at the level of the syndesmosis type B، أما إذا level of the fracture fibula high than the syndesmosis is type C. طبعا كل ما نيجي من A to B to C كل ما يزيد instability and need for the surgical fixation. Regarding the type A, is the transverse fracture of the fibula below the tibiofibular syndesmosis, perhaps associated with oblique or the vertical fracture of the medial malleolus. This is almost certainly an adduction or adduction and internal rotation injury, the mechanism of the injury. While type B, it is an oblique fracture of the fibula in the sagittal plane at the level of the syndesmosis. Often there is also an avulsion injury on the medial malleolus, a torn of the medial malleolus, or sometimes a fracture of the medial malleolus. This is probably an external rotation injury. and the last one اللي هو type C, the most severe one, above the level of the syndesmosis, the fracture of the fibula, which is mean that the tibiofibular ligament and part of the interosseous membrane must have been torn. This is due to a severe abduction or combined of the abduction and external rotation. Associated injury are avulsion of the fracture of the medial malleolus or rupture of the medial collateral ligament. Posterior malleolar fracture may be associated and diastasis of the tibiofibular joint. There is common variant of the fracture which is a Mazzonifa fracture اللي هو fracture of the proximal fibula with the syndesmosis disruption. For any syndesmosis disruption should be take all the leg x-ray in order to rule out of the fracture around the neck of the fibula. وبالحالة هذا المريض يحتاج sometime examination of the common peroneal nerve لأن مثل ما تعرفون ال common peroneal nerve يجي around the neck of the fibula. Clinically, the ankle fracture are seen in skier, footballer, and climber, or old group including women with postmenopausal osteoporosis. The ankle is swollen and deformed. The site of the tenderness is important. If the medial and the lateral side are tender, double injury, bony or ligament injury is suspected. For X-ray, at least 3 views are needed: anterior, posterior, lateral, and 13-degree oblique اللي هو mortise view. The level of the fibular fracture is often best seen on the lateral view, while diastasis may not be appreciated without the mortise view. Sometimes further X-ray may be needed to exclude any proximal fibular fracture to rule out of Mazzonifa. Regarding the fracture management, swelling is usually rapidly and severe, particularly in the high energy trauma. If the injury is not dealt with it within a few hours, definite treatment may have to be deferred for several days while the leg is elevated so that the swelling can be subsided. Fractures are visible on the X-ray while the ligaments are not. Always look for the clue to inevitable ligament injury. إذا راح نشوف sign بالإكس-راي نتوقع إذا هو there is a ligament injury. إذا شفنا number 1 widening of the tibiofibular space, it is indicated of ligament injury. أو asymmetry of the talotibial space. Number 3 widening of the medial joint space, and lastly when see any tilting of the talus, it is when there is no sign of a fracture indicated there is ligament injury. In assessing the accuracy of reduction, 4 objectives must be met. Number 1, the fibula must be restored to its full length. During management of the ankle fracture على مود يؤسس انه انت accurate reduction. Number 1 لازم الفيبولا ترجعها الى full length. Number 2, the talus must be squared in the mortise within the talar and the tibia articular surface are parallel. Number 3, medial joint space must be restored to its normal width. أي اللي يقصده انه الويدث the same as the tibio-talar space اللي هو about 4 ملم اللي شرحناه سابقا. واخر شيء oblique fracture oblique x-ray must be show that there is no tibiofibular diastasis. So we have two strategy, whether an operative or conservative. When there is a patient with undisplaced fracture, the first step to decide whether the injury is stable or unstable. Undisplaced Dennis-Weber type A fracture is stable and need minimum splintage, while undisplaced type B Dennis-Weber fracture are potentially unstable, and thus below knee cast is applied within the ankle in the neutral anatomical position for 6 to 8 weeks, while type C Gensweber and undisplaced fracture better fixed internally لأنه it is usually changed to the unstable. While displaced Gensweber type A of fracture, internal fixation of the malleolar fragment with 1 or 2 screw. While type B of fracture, the most common fracture pattern is a spiral fracture of the fibula and an oblique fracture of the medial malleolus. If a close reduction succeed, a cast can be applied and following the same routine as for undisplaced fracture. Otherwise, open reduction and internal fixation. While type C of fracture displaced, almost all unstable and require open reduction and internal fixation, where the main indication for operative is instability and talar subluxation, malposition, whether joint incongruity or articular step off. This is picture showing the open reduction and fixation of the fracture of the fibula by plating and screw and the medial malleolus by screw. The outcome, a stable ankle fracture without lateral talar shift, treated conservatively, have a 19% good to excellent result. And also operative fixation of any stable ankle of fracture is the same percentage good to excellent result. What about the complication? There is early and late complication. The early complication usually vascular injury and wound breakdown and infection, especially in diabetes. While late complication, number one is incomplete reduction unless the talus is fit in the mortise and accurate reduce, degenerative changes may be occur. Number two, non-union. The medial malleolus occasionally failure to unite it because there is a flap of periosteum is interrupted between it and the fibula and the tibia, and thus should be prevented by operative reduction and fixation. Also, other complication later is a joint stiffness and oligodystrophy. Start within the fracture calcaneum. fracture calcaneum مقولة بانكهارت عام 1942 result of the crush fracture of the os calcices are rotten. The calcaneal fracture is the most common fracture talus bone, and about 10% of the cases both heel are injured simultaneously. Fractured calcaneum, there is a high potential for disability, pain, gait disturbance, and unable to walk. And also the best treatment of the fractured calcaneum is controversial. Both of them conservative and operative with high chance of the complication. Regarding the anatomy, this is the calcaneum and this is the talus, and the most important between them is the subtalar joint اللي هو اللي يهمنا subtalar joint. Regarding the mechanism of the injury, in the most cases the patient fallen from a height, often from a ladder, into one or the both heel. The calcaneum usually is driven. The calcaneum usually is driven up against the talus and it is split or crushed. Over 20% of the cases suffering associated injury of the spine, pelvis or the hip. لذلك أي واحد يجي within the fracture calcaneum, the next examination is the examination of the spine and then the hip. This may be associated with vertebral fracture or the hip fracture. SS Laprosti classify the calcaneal fracture into two types, extra-articular and intra-articular. Extra-articular fracture involving the various calcaneal processes or the tuberosity of the body of the fracture and substanticulum of fracture, which is mean fracture not reach to the subtalar joint, while the intra-articular fracture though that split the talocalcaneal articular face. Regarding the extra-articular fracture, these account about 25% of the calcaneal injury. Avulsion of the anterior process or the substanticulum tali or the tuberosity or the inferior medial process fracture of the posterior extra-articular part of the body are caused by compression. Extra-articular fracture are usually easy to manage and have a good prognosis by closed method, unless the fragment is large and badly displaced. In this situation, usually can be fixed back by screw. While the intra-articular, the impaction of the talus cleavage the bone from above to produce a primary fracture. A primary fracture line that is run obliquely across the posterior articular facet and the body from the posterior medial to the anterolateral, from the posterior medial to the anterolateral. The upward displacement of the body of the calcaneum produces one of the classical X-ray of depression type of fracture, and the angle subtended by this can be measured by what we call Bohler angle, and the Bohler angle is the angle subtended by posterior articular surface and the upper surface of the body posterior to the joint. Normally is between 25 to the 14%. And then we have a primary and secondary line. Secondary line usually produce what we call tongue tie, which is mean more than two pieces of the calcaneum, and one of them will become floating. Thus, in the fractured calcaneum, there is articular incongruity, there is a hind foot varus. Also, the shape of the foot become wide and loss of the height. It can become short, يعني leg length discrepancy. Also, there is a perineal impingement and heel pad crushing. Imaging, we have standard view and also lateral and axial view to well identify the fracture of the calcaneum. And CT scan is very important and vital to assess the severity of the fracture. And regarding the clinically, the foot is often painful and swelling, and the large bruise appear on the lateral aspect of the heel. The heel may be look broad and squat. The surrounding tissue are thick and tender, and the normal concavity below the lateral malleolus is lacking. The subtalar joint cannot be moved, but the ankle movement is possible. There is no ankle movement away from the calcaneum. "57% of the long-term symptom the patient presented after fractured calcaneum, and also 95% of those patients cannot be walking on an even ground, and also 75% of those patients with a broad heel. The standard treatment is controversy. Results are not good enough, whether operative or conservative. ولكنه our aim of the treatment is restore to anatomy and restore to the function and prevent arthritis, and typically restoring the articular anatomy thus would be give improved result if the complications are avoided. This is the open reduction and intern fixation by special plate اللي هي هذه البليته بليته خاصة للكالكينيوم. ولكن الكومبليكيشن in the fracture calcaneum, including, as you know, malunion, stiffness, subtalar arthritis, peroneal tendon injury, sural nerve pain, heel pad problem. This is conservative complication. Plus, if it is used operative wound problem اللي هو atypical wound necrosis and infection. Other fracture is the fracture of the talus, or what we call a Vater fracture. Talar fracture and dislocation are relatively uncommon. They usually involve considerable violence, اللي هو car accident or falling from a height, or severe wrench of the ankle joint. The injury usually include fracture of the neck, body, head of the body, head, bony process of the talus, and dislocation of the talus or the injury around the talus. This is the anatomy of the talus, which is articulated within the calcaneum. The important fact regarding the talus is a major weight-bearing structure. The surface, articular surface, carry a great load per unit area than any other bone in the body, because 16% of the surface of the talus is articular and there is no any muscle attachment. The next is blood supply. The talus has a variable blood supply and it is a relatively common site for post-traumatic ischemic necrosis. The head of the talus is richly supplied by intraosseous vessel. However, the body of the talus is supplied mainly by vessels that enter the talar neck or from the tarsal canal and then run retrograde from the distal to proximal. مثل السكافويد and the fracture neck femur. In a fracture of the talar neck, the vessels are divided and injured. In the fracture of the talar neck, these vessels are divided. In a fracture are displaced and extraosseous plexus also too may be damaged and the body of the talus is at risk of ischemia. The incidence of the fractured talus about 2% of the all fracture, 6 to 8% of the all foot fracture, and it's important due to high complication rate after fractured talus, which is include avascular necrosis, post-traumatic arthritis, and malunion. Regarding the mechanism of the injury, violent hyperextension of the ankle, the neck of the talus is forced against the anterior edge of the tibia, which is act like a cleaver. Fracture of the talus is usually a compression injury due to a falling from a height or a severe everting force across the body. Neck of the talus embed anterior distal tibia لذلك يؤدي إلى fracture neck of the talus. وإذا الforce will be continuous, also there is talar body dislocation and usually it is occur around the deltoid ligament. Previously كان يسمونه a Vater fracture and usually it is due to motor vehicle accident or from a height, and usually the patient presented with multiple injured patient in about 15% of the cases. Special X-ray اللي هو يسمونه الانكل بلانتي فليكشن اللي هو canal view اللي هو 15 degree of the pronation and the tube 15 degree of vertical. MRI is very important rule, especially to assess the complication like avascular necrosis. Regarding the classification fracture of the neck of the talus, these fracture classified by Hawking into 4 types. Type number 1, it is undisplaced fracture with about 30% of the avascular necrosis complication. Type 2 of fracture It is a displaced little and associated with subluxation or dislocation of the subtalar joint, and this is about 20 to 15% of avascular necrosis. Type 3 fracture, the displacement with dislocation of the body of the talus from the mortise, from the ankle joint, and this is about 83 to the 100% of the complication. And type 4 when it's associated also within talonavicular joint disruption, and 100% of the complication of the avascular necrosis. Our goal of the management is to immediate reduction of dislocated joint. Number 2 is anatomical fracture reduction, stable fixation in order to facilitate union and to avoid complication. Regarding Hawking type 1 fracture, usually it is non-displaced, non-weight bearing cast for 4 to 6 weeks, followed by removable brace and motion, and sometimes percutaneous screw fixation and early motion in order to prevent the displacement. While type 2, type 3, and type 4, when there is a displaced fracture, result depending upon develop of the complication, whether osteonecrosis, malunion, and arthritis. Immediate reduction of dislocation joint is very important to prevent or decrease the complication, but the calcaneal fracture usually it is associated with other life-threatening condition that will be taking the priority, and next will be take the fracture calcaneum management. Close reduction of the type 2 can be very useful, particularly if there is no life-threatening conditions appear. ولكن it is difficult in type 3 and type 4. This case within the type 2 displaced fracture, usually reduced by manipulation under anesthesia and sometimes in the life-threatening condition you can be used external fixation. It is a span external fixation, temporalize the crossing the external by fixing the tibia within the calcaneum until the life-threatening condition resolve, and then will be proper treatment of the calcaneum of the talus fracture. The main complication of the talus fracture is avascular necrosis, non-union, malunion, and arthritis. Avascular necrosis, plain X-ray, you see the sclerosis and decreased revascularization, and the best method for diagnosis of the avascular necrosis is by MRI. Malunited usually within the varus hind foot, وراح نشوف الميد foot is supinated and on the clinical examination. Also arthritis incidence about 30 إلى 90%، ولكنه non-union it is uncommon even when there is avascular necrosis. Delayed union very common and the frequent result in late malalignment. The next fracture is the fracture of the fifth metatarsal or base fracture اللي يسمونه Jones fracture. Jones fracture Jones fracture, the mechanism of injury is the force inversion of the foot cause avulsion of the base of the fifth metatarsal اللي هي peroneus brevis tendon, or sometimes the lateral band of the plantar fascia, usually presented with severe pain and cannot be walking. The treatment usually by rest and support, or sometimes operative fixation if the fracture is reached to the articular surface. And the last fracture is the citrus fracture or march fracture, usually is occur in the young patient, usually due to minor repeated trauma. It is citrus fracture usually in the second metatarsal, sometimes third metatarsal. The X-ray initially normal, but the radioisotope scan is positive. Patient presented with the pain in the forefoot. After 4 to 6 weeks usually راح نشوف mass of the callus appear on the X-ray. Usually non-displaced fracture and neither reduction nor splint is necessary. The forefoot may be support within elastic banding and normal walking is encouraged. Thank you for your listening.